much. So we'll have the next talk by Dr. Sujata Mohan. As we know, Dr. Sujata is excellent phacosurgeon and also a cornea surgeon, and she'll be talking to us on when and why do we implant toric IOLs.
Good afternoon, everybody. At the outset, I'd like to thank Dr. Haripriya for inviting me for this talk. My talk is on toric IOLs, when and why. So why toric IOLs? They provide a safe and a very predictable option for cataract patients who have a pre-existing corneal astigmatism, and very minor modifications have to be done in the cataract technique for achieving success. It's a very small learning curve for any surgeon. So this was a study in the Holiday database which analyzed 3,538 eyes, and they found that 4 out of every 10 routine cataract surgeries needed astigmatism management, and the average K astigmatism was clearly close to 1. So this is again a study which showed that out of 1,230 eyes, that is 40% of the patients undergoing routine cataract surgery had more than 1 diopter of preoperative astigmatism. So why should we talk about this? Is it of big significance to wear a -1 glass? No, because then you don't get the wow factor after cataract surgery, because today the cataract surgery has become a refractive cataract surgery, and the expectation of the patient has risen a lot. So it's important that you give the wow factor for you to get the next patient, because the patient is otherwise going to have image distortions. Patient has to wear glasses. There can be a starburst phenomenon, diplopia, and so on. This is again a study which showed what was the effect of uncorrected astigmatism, even as low as 1 diopter, if left uncorrected, could significantly affect the patient's independence, quality of life, and well-being. And this is a simulated distant image showing the degradation of images, though the patient is able to read 6 by 6. Towards the end, you can see the 3 images. With the cylinder, it's totally blurry. So it is important that we take care of the astigmatism as much as we take care of our spherical errors. So refraction, we all say, is not a true indicator of corneal toricity, because what we're going to do in a toric IOL is correct the corneal toricity. And this can be done in various ways, using a manual keratometry, topography, a lens star, or IOL master. The most important thing first is, before you start the workup, you have to make sure the patient doesn't have a dry eye, doesn't have blepharitis or MGD, which can affect the ocular surface and therefore affect your keratometry, topography, the refraction, and the astigmatism that we're looking at. What are the special concerns? What do we do when a patient comes with a pterygium? Do you do your combined surgery, cataract pterygium, or do you do a topography to rule out induced astigmatism? It's important that you do a topography, because most of these patients, particularly when the pterygium is a little bit extended into the cornea, can have a significant flattening at the area of the pterygium, which could induce a cylinder, and which will be correcting with the lens. And once you remove the pterygium, then what's going to happen is patient is going to have an unnecessary cylindrical error on top. So it's before a pterygium surgery, before you do a cataract surgery, it's important you do a topography, and then do the pterygium surgery first, wait for a couple of months, and then take up the patient for a toric IOL if required. In case of post-PK astigmatism, again, wait for all the sutures to be out before planning toric IOL. Wait for 3 months before the last suture, and then you plan a toric intraocular lens. But in some situations, you come across a patient who is still having the sutures and then needs a toric IOL. So you have to make sure that this patient is corrected. You have discussed with the patient what's going to happen if you put a toric IOL, whether you're going to remove the sutures or not. So this is other preoperative consideration in this case would be a graft clarity, look for specular microscopy, the type of astigmatism that you're correcting, whether it's regular or irregular. You can see there are 2 types. One is a very regular astigmatism after post-PK. The other one is very irregular. So pre-op evaluation, a PK patient would be a stability of refraction after suture removal. Post-PK corneas are very difficult to assess both by digital and optical biometry, so beware of that. And topography for confirming the degree and the type of astigmatism. So whether patient is on rigid contact lenses, if the patient is already on rigid contact lenses, very comfortable with it, don't put a toric lens. Just put a monofocal and let him continue to wear his rigid lenses, because the quality of vision that he gets with a toric rigid contact lens cannot equal a toric lens. So this is one of my patients who had a 15 diopter astigmatism. You see, I have operated in 2003, this was in 2004, and I did a selective suture removal, after which her astigmatism dropped to 7. And this was in 2000, till 2014, she maintained the same thing. And in 2016, she required a cataract surgery, and you can see that the cylinder is maintaining more or less the same. It's about 7.44, which also corresponds to the lens star astigmatism. So I did a customized toric IOL for her. There are some Indian companies which will make the toric IOL based upon the, you don't get them in regular lenses, so you have to customize the lenses. So patients with advanced keratoconus is again a problem. Even patients with low astigmatism per se can have a problem with toric IOL. So you really have to think about it, do a topography to see what type of cornea they have. In case of high astigmatism, absolutely avoid toric. Patient can either go back to contact lenses, or you can fit him with many scleral lenses. So this is a patient who has 53-year-old patient with cataract. You can see the right eye has a 2.75 sil, the left eye has a -7 sil. I wouldn't correct both the astigmatism, because the right eye, though the spectacle cylinder is only 2.75, you can see her corneal cylinder is 4.28. So it's better that you do a monofocal, because somehow the patient finds a null point through which she has been using it all these years. And if you correct the cylinder, maybe you will be inducing a cylinder or disturbing her already perfect vision. Again, in advanced keratoconus, pellucid marginal degeneration, it's better to avoid surgery. Toric IOL. So post-refractive surgery is again a problem. We do come across patients like this with very bad decentered ablation, and they have been living all their life. Somehow they managed it very well, and this is in the era before the eye tracking. So you don't go and mess with them, because you can see the cylinder is about 4.35 corneal cylinder. Please don't try to implant a toric IOL. Again, a post-RK topography. Post-RK, we're going to have other problems like hyperopia shift and other things, so implanting a toric IOL again has to be considered. So an ideal candidate would be an astigmatism of 0.75. It's got a regular astigmatism, no pre-existing cochlear pathology, and you have to give careful consideration to previous ocular and refractive surgery. Relative contraindications are zonular instability, PCO, posterior capsule dehiscence, poor pupillary dilatation, prior surgeries such as VR surgeries, scleral buckling, and glaucoma implants. So what are why do we stop doing toric implants? Is because we have our doubts. So if you improve your surgical skill to that extent that you can perform cataract surgery consistently, then it's the time to shift to toric IOLs. Selection of patient is important, stress on accurate biometry, and take simple, well-dilated pupils as the first a few cases. And monitor your results over a period of several months, and then also important that you increase the chair time. Audit your cases diligently, and take time for counseling and motivating patients. So this was one of our study we did quite a long time back. You can see that out of 50 patients, 90% of the patients had very good results, and the astigmatism dropped from about 2.25 to about 0.5. And when we compared the results with other similar studies, we found the uncorrected visual acuity was 94% or better in most of our patients, and 96% of the patients had less than 1 diopter astigmatism. So it's important that you also audit your own results. So patient satisfaction is also very important. Most of the patients are very happy because they get rid of their astigmatism as well, and the quality of vision is much better. The wow factor is there. So accurate, to summarize, accurate keratometry, accurate topography, accurate biometry, IOL power calculation, consistent surgery, a well-centered rhexis, and accurate marking is also very important. So there are various methods of making it all accurate, including your surgery, is that you can use some of the newer modalities, such as the Callisto, which I'm using, which will give you an idea about how to perform the rhexis. It gives you a virtual image, and also where to implant the lenses. Thank you.
So we heard many useful tips and some good cases as an examples. Any questions for Dr. Sujata? So I just wanted to have a question. Would your cutoff be different for a with the rule astigmatism? A patient who's say 35 years, who has 1.25 diopters with the rule astigmatism, would you advise a toric IOL?
I would.
You would?
Because they have another 15, 20 years to go before it changes. I would, yes.
So I would probably refer on that. So I would, in young patients with lesser astigmatism, it's again a matter of choice. I would probably do an LRI, because that astigmatism may reduce over the course of time. So again, it depends upon if is it with the rule, is it the patient's age, coexisting conditions. So, I mean, we all have, I think it's based on our experience and what works in our hands, but we'll have to remember. Again, there's a question of, if you have a patient with advanced cataract, a grade 4 cataract, older patient, 80 years, and the patient has significant astigmatism. The question is, even phaco is difficult. Should we implant a toric lens? I think we should, because I think patients who receive toric IOLs are one of the happiest group of patients because they have much better contrast, their quality of vision is better. So if you can do a phaco, and if they have significant astigmatism, I think we should give them the benefit of better unaided vision. So thank you, and we'll go on to the next